Welcome to our Mary Greeley Primetime Alive presentation, Foot and Ankle Pearls from an Orthopedist's Perspective. I'm Vicki Newell and I manage the Primetime Alive program. As a reminder, if you would like more information about Primetime Alive or information on how to join, you can visit our website, mgmc.org/PTA. Our presenter today is Dr. Christy Christofferson. Dr. Christofferson received her Bachelor's of Science from St. Mary's University in Minneapolis and her medical degree from the University of Minnesota Medical School. She completed an orthopedic surgery residency at Mayo Clinic and a foot and ankle fellowship at the University of Rochester in Rochester, New York. She joined McFarland Clinic in September of this year. Please welcome Dr. Christofferson.
Hello, everyone. It is my great honor to be talking to you today. However, I must say, as convenient as it is for you to be watching me at home, I wish I could see your smiling faces instead of an empty auditorium. But hopefully we will conquer COVID soon and it will be safe to return. I realize my title is somewhat of a mouthful. The reason let me back up a little bit. My goal in creating this talk is to give you somewhat of an overview of what I see in my practice and to touch on questions that I've received from patients and also patients that I have seen. I will do my very best to keep you engaged. Please send in your questions so I can try to talk about what is most meaningful to all of you. The number one question I probably receive from patients is, what makes me different? And the way I like to think about that is, first, I'm a physician. I've been trained to not only think about the body as a whole, but also being mindful of the mind-body connection. And with that in mind, I like to think that I treat my patients as a whole being rather than simply looking at their foot and ankle. Secondly, I am proud to say that I graduated from the Mayo Clinic with my orthopedic residency. And of course, a huge part about orthopedic training is learning biomechanics and studying things like fracture management and joint replacement. But I think the thing I am most grateful for is being taught how to correlate my clinical findings with my radiographic images. One of the first, and just as an example, one of the first places, if we're lucky enough to live long enough, we get arthritis, is in the midfoot. But just because I see arthritis in a midfoot does not necessarily mean that I treat it. It only really is important to me is if it's causing pain with my patients. Let's see here. Is there anything else? Oh, yes. And I had a great year in New York, which is where I'm most recently coming from. Training in New York was great, but my patients in New York were very different than my Iowan patients. And I must say I am incredibly grateful to be a part of this community. I say that Iowans are somewhat magical. You all are definitely stoic, sometimes to a fault. But bottom line, I know that if my Iowan patients are telling me they have pain, it's something that I need to look into. I did post a few objectives just for completion's sake. I've been told that you have all received my slides. So I'm just going to talk about a few miscellaneous pearls. Believe it or not, even as an orthopedic surgeon, I would argue that not all fractures require operative intervention. We're going to talk about everyone's favorite, plantar fasciitis. Briefly touch on ankle sprains, as well as common foot deformities and arthritis. One of the questions I've received since I started here is if I perform elective procedures on people who use tobacco and nicotine. And the answer is no, because as orthopedic surgeons, of course, we are very worried about controlling or doing our best to control postoperative infections. And this puts my patients at an increased risk. Now, of course, trauma is a different animal. But as far as elective procedures are concerned, I do not operate on smokers. Other factors that lead to increased postoperative complications include comorbidities such as diabetes, peripheral artery disease, neuropathy, and impaired immune function overall. The American Diabetes Association recommends avoidance of elective surgery if hemoglobin A1C is greater than 7. However, some argue that 7 is too low and that cutoff should really be 7.5. The way I look at this is I think that it should be discussed between my patient. I think it's worthy of a discussion. All right, like I said, we're gonna start talking about fractures that don't necessarily require operative intervention. A pretty classic one is base of the fifth metatarsal fractures. Some of these, it's reasonable to operate on, because depending upon the zone it's in, they may be at an increased risk of non-union or not healing. But the vast majority of these are going to heal without a problem. I have this X-ray right here. Let's see here. I think you can see this. And there is this little fracture line right here. Okay, thank you. I'll go up over here. I was told otherwise, but I will use the screen. Here's this little fracture line right here. This was an 18-year-old patient of mine who initially had been told he needed surgery by another provider. His mom is a physician in the Twin Cities and found me and asked if I would see him as a second opinion, which of course I said yes. This fracture almost never requires surgery because of the location. And I immobilized him in something I call a carbon foot plate, which is quite nice because you can slide it right into your regular shoe and it immobilizes a painful foot. We'll talk about it a little bit more as we go on because I use it actually quite often, especially with things like arthritis, etc. Let's see here. Yeah, so he healed without problems and without surgery. These x-rays are actually pictures of a 64-year-old female patient of mine. And here you can see this fracture line right here. This was her initial x-ray. She also came to me as a second opinion. She was told that she needed surgery, but she did not want surgery. And we had a conversation because I have no problem trying to treat things non-operatively when indicated. And truthfully, this fracture is a little bit of a gray zone. But in the end, if it doesn't heal, then it would, and if she was painful, then at that point we could operate. But fortunately, here's her x-ray 6 weeks after her initial injury. And if you look here, this is a little bit of gray. I like to say the way that bones heal, if you don't operate, is similar to the way our skin heals if we get a bad wound. If you get a bad laceration or a bad cut that's not sutured, your skin becomes hypertrophic, so you get this big scar that eventually remodels over time. The bone does something very similar. So this gray that you can see on this x-ray right here, that represents a bony scar or a callus. A bony callus, which indicates healing. So she, I think, is going to heal without problem, and she didn't even have to have surgery. Isolin disease is something we see in our pediatric patients that's often misdiagnosed as a fracture because you have this line right here, which looks very similar to a fracture line, but it isn't, and it certainly doesn't need surgery. All right, now we are moving on to plantar fasciitis. I realize this is probably not the most exciting thing we could talk about. However, I think it's important for a few different reasons. Number one, I'm guessing most of us have probably experienced plantar fasciitis at one point in our lifetimes, or I'm guessing you know friends who have. So I want to start talking about plantar fasciitis with talking about the plantar fascia. The plantar fascia is this very thick and relatively inelastic tissue that doesn't, again, it's relatively inelastic, so it doesn't really give very well. But it's important because it's responsible for the transmission of tensile force while we're walking. So during our gait pattern, it's what helps propel us forward. However, repetitive activation leads to tensile overload and can then lead to micro tears and inflammation. Plantar fasciitis is the most common cause of heel pain. And the problem is it takes forever to heal and recover from. Most patients have resolution of pain within 10 months, but 10 months is a really long time. And then even 10% go on to have longer pain. Pardon me. If you look at this x-ray, you can see this little plantar spur. Several years ago, we used to think that this plantar spur represented trauma to that plantar fascia. And it was not uncommon for other providers to try to go in and remove this spur. However, what we believe now is that it's probably not representative of the plantar fascia as much as attached to the deeper musculature in the foot. Therefore, we don't really think too much about this plantar spur anymore. Additionally, it can be present in patients without plantar fascia pain. So I put this x-ray up in case any of you have heard about this plantar spur being a problem and just to help educate. Now, plantar fasciitis, I'm pretty convinced, is probably a multi-billion-dollar industry. Everyone, it seems, is willing to sell people some type of treatment for plantar fasciitis. And some of them are more useful than others. When a patient comes to my office with plantar fasciitis type pain, the first thing I start them with is plantar fascia specific stretching. And we'll go into a little bit more detail of that particular stretch later, actually in the next slide. Gastrocnemius stretching, which is your calf muscle, can be helpful, especially if patients also have a tight calf. Night splints. So I want to back up for a second and talk a little bit about the pathogenesis or the reason why plantar fasciitis is a problem for people. So as humans, when we're in our position of rest, whether it's you're watching, TV on the couch or you're sitting at your desk or you are sleeping, our toes are pointed because that's comfortable. Now, if you think about it, the plantar fascia attaches at the heel and the toes. And if our toes are pointing, the plantar fascia is tight. And then when we go to make that first step out of bed in the morning or after we've been resting, it stretches out that plantar fascia. And what happens, the reason why you get heel pain is because it literally pulls off that calcaneus. It pulls off that heel bone and microfractures or causes really small fractures in that heel bone. This then leads to this whole cascade of inflammatory changes, which the reason why that's important for us is because that is what causes pain. And so if we don't address it, every time you wake up in the morning or every time you get up after you've been resting, you're going to tear off that plantar fascia a little bit from that heel, and you're going to restart that inflammation cycle all over again. So the key is to keep our toes from pointing. Pointing is not good for plantar fasciitis. So that's why things like the plantar fascia stretch I'm going to show you next works. That's why things like the night splint like this works, because it prevents you from pointing your toes. Other things that have been described would be orthotics or shoe modifications. I don't really buy into that as much. I do like orthotics and shoe modifications for a lot of things. However, personally, I don't know that it's all that beneficial for plantar fasciitis. Pardon me. The other things that can be useful, I really like Voltaren gel. It's also called diclofenac. It's basically like putting ibuprofen right on the part that hurts you. The nice thing these days is it's over the counter. And instead of a pill, like ibuprofen is, it's a gel. So because you're not swallowing it, it's not going systemically. It's not being systemically metabolized and causing damage to things like your GI system and your kidneys. Voltaren gel or diclofenac stays very localized. The other thing that I like about it is the foot is pretty cutaneous. It's really just skin and bones, which means there's pretty excellent penetrance. So I think Voltaren gel is always a good option. The other thing that's not uncommon as a treatment for plantar fasciitis is a steroid injection. However, the problem with steroid injections into the plantar fascia is it can cause rupture. And if it ruptures, there is not great treatment. We don't have reliable surgical intervention that we can do for a ruptured plantar fascia, and it takes a really long time to heal. Other things that, another thing that works well is a cast, which we'll talk about in a little bit more, and shockwave therapy. I haven't heard of as much shockwave therapy here in Iowa as I did in New York. New York, people liked it, but it's expensive, and insurance didn't cover it. So it's not something I sent my patients for. All right. So we're going to talk a little bit about this plantar fascia specific stretching. Again, this is the first thing that I tell my patients and I go through with my patients in clinic when I see them for plantar fasciitis. Now, the key is you're going to try to stretch out this plantar fascia before you take your first few steps out of bed in the morning. And as we age, I know that our joints become a little bit tighter. So I will talk about this particular exercise. However, we'll mention modifications if you can't bend this well. So I tell patients to take their affected leg and cross it over the other, just like in this picture. And you're going to take the hand, your same hand. So let's say you have plantar fasciitis of your left foot, like this guy does. And so he's taking his left hand, so the same hand as it's affected on his foot, and he's kind of pulling his toes, preventing them from bending or from pointing, which is, of course, how that plantar fascia stretches. He's pulling his toes, pointing them towards his knee or towards his shin and a little bit towards the ground. And then with your other hand, you're going to kind of feel this plantar fascia. It's a tight band. And what I tell patients is to go find that spot that's really painful on your heel. I have issue with this picture a little bit because I think normally the spot that's pretty tender is right here. And what I tell patients is to really deeply massage that area. You don't have to do it for long, even 30 seconds, but I say that you should be doing it about 6 times a day. I say 6 times, that's somewhat of a magical number. It doesn't have to be exactly 6. But I think it's important to do it before you get out of bed in the morning, before your first few steps, after you've been resting on the couch, etc. So I assume people get up approximately 6 times a day, which is where the number 6 came from. Now, your goal here is to kind of break up this plantar fascia where it hurts most before you have an opportunity to tear it. Now, if you can't quite bend this well and get into this position, another thing you could do is like get a hard ball, like a lacrosse ball, and use that to kind of massage in that area. Or you even put your foot on the floor and kind of massage into that painful spot. That's also helpful. Things that I do for refractory plantar fasciitis is when patients come to me after I've seen them before and I know that they've been doing their exercises or I've instructed them to do their exercises, I ask them to show me what they've been doing, and then we go through it again. Then the second step is I threaten to put them in foot jail. And what that means is a cast for a month. Now they're allowed to weight bear, they're allowed to walk with the cast. Truly the reason why the cast works is it prevents you from pointing your toes. It keeps your foot dorsiflexed to this position. Other things, again, shockwave therapy, which we talked a little bit about. Success ranges vary. There's another thing called a topaz procedure, which is essentially putting tiny little holes through the plantar fascia. And that's done in the operating room. But now the key is, after the microtonomy or the topaz or the small holes, I lock them up in foot jail again for another month. Now the holes are somewhat beneficial because it's actually allowing that plantar fascia to stretch a little bit. But I don't know if the micro holes or the putting them in foot jail does the best, is more helpful from that perspective. Also, plantar fascia with nerve release is another surgical option. But again, varying success rates with that procedure. We're going to talk very briefly about ankle sprains. Ankle sprains is one of the most common things musculoskeletal thing that we see in our emergency department every year. There's approximately 2 million acute ankle sprains yearly in the United States. Most of these respond very well to non-operative treatment with physical therapy, but some don't. And the ones that don't improve, they require additional workup. And we'll talk about these very briefly. This was a study I found that looked at 433 ankle x-rays, and they found that 18 of these were incorrectly interpreted at initial reading. Now, here at McFarland, we are very lucky. I have amazing radiology partners, but we still miss things here, not because they don't read the x-rays very well, because they do. That's not the case at all. The problem with x-rays is they're not always sensitive enough to pick up the pathology, which is why it's important to have a high index of suspicion. Here is an example. This was a patient that I saw in my clinic. He had a bad ankle sprain. He went to physical therapy, was not getting better. This was his initial x-ray after his injury. He also had an MRI after his injury. And what was missed, however, is lateral process of the talus fracture. So this is your ankle. The bones that make up your ankle is your tibia, your fibula, and your talus. With a typical ankle sprain, it's one of these type deals. And in this particular patient, he fractured right here. Now, when I saw him in clinic, he was very point tender right in that spot. So I had a high index of suspicion that that was his problem. And I ordered a CT scan. Just to back up a little bit, MRIs are excellent for soft tissue, but sometimes it's harder for us to see bone, especially details of bone, whereas a CT scan is much better from that perspective. So as you can see, the CT scan picked up the little fragments of his fracture, and then I brought him to the operating room to just remove these fragments. Now, not always are they this small. Sometimes they involve a larger portion, and the problem is if they're missed, they can lead to early arthritis. Another fracture that is seen in combination with ankle sprains is called the anterior process of the calcaneus fracture, and that's this one right here. You can see this little fracture line. A Maisonneuve injury is also possible, and that is basically where you have an unstable ankle. Now, it can be tricky because patients typically present with ankle pain, and if you don't have a high index of suspicion, you may not examine the knee, and it's possible to then miss the proximal fibula fracture, which is right here with this fracture line. And these fractures rarely occur in isolation. Usually they mean that there's an unstable ankle. These x-rays are also important because this was the x-ray that this patient came in with. But this was the x-ray. This was the quote-unquote stress view that was performed in the operating room. And you can see this increased space right here, as well as right here, compared to this space, which is relatively narrow, and this space, which this ankle, if you don't have a high index of suspicion, could look normal, whereas this ankle is unstable. And these are the same patient, just in different types of x-rays. Additionally, osteochondral talus fractures are not uncommon. And then if patients have had several sprain-type injuries, they can go on to develop chronic lateral ligament instability. Your peroneal tendons are tendons that run behind the fibula, and with a bad ankle sprain, they can also be strained and create pain. The other thing that we see peroneal tendon issues quite frequently with is something called a cavovarus foot. Now, I typically see two different types of foot deformities. Number one is a flat foot, and number two is a high arched. This cavovarus deformity is a high arch deformity. And again, when I see a foot like this, I don't get too worried unless my patient is having pain and symptoms. Then that's when I start treating things. If they have a funny looking foot, but no problem with it, then that's okay from my perspective. I'd like to tell my patients that I have a lot of tools in my toolbox, but we don't always need to use them. The important thing of the high arch type deformity is it can represent all kinds of different pathology. As a foot and ankle orthopedic surgeon, it is not uncommon for me to be the first person that is alerted to some of these things in kids. Something like Charcot-Marie tooth, which typically presents with a high arch and can lead to other more devastating things if it's not caught. Other things, a stroke can cause this funny foot shape. Now, don't get me wrong. Just because someone has a high arch does not mean that they have deeper pathology. But as a physician, I think it's incredibly important for me to be alerted that these things exist. Because if I'm not thinking about them, they could be missed. Dr. Moore, who's a neurologist here, pardon me, sent me one of his patients recently. This patient is a late 50s, I think. He's still actively farming. Back in 2013, he had a stroke, and he's doing very well, but his one foot is becoming a little bit more difficult to put a brace on. And so it's giving him this kind of high arch type foot. Now, fortunately, Dr. Moore sent him to me early, because right now, even though his foot is becoming a little bit more challenging with brace wear, he still has good joint spaces, and I can still passively correct him to neutral, which means it's early enough that if he chooses to have surgery, I can do soft tissue type procedures rather than bony procedures, including fusions, etc. So these are just some pictures of this funny type foot, this cavovarus. So you can see this picture here, it looks a little bit more like a normal foot than this one does. But please note, with the high arch, it's just one thing that I think about that kind of tips me off to look for other things. Here's just some x-rays of again, this cavovarus deformity. And also affects your midfoot and forefoot, which again, this is just showing that. Now, the reason why cavovarus deformity can be troublesome for patients is because less stress is dissipated while walking, during the gait cycle. Because the hind foot remains in this funny inverted position, something like this, which then locks up the midfoot. And the forefoot kind of drifts a little bit. This can lead to lateral foot overload or pain in your like fourth and fifth raise. And the reason why that is because you have this high arch, and so there's more weight that's being your lateral border. So your fifth metatarsal and your fourth metatarsal is just seeing more load and more weight than the foot is designed to. So it can lead to metatarsal stress type fractures. It can also lead to plantar fasciitis and lateral ankle and tendon injuries, including the peroneal tendons, which we talked about a few slides ago. Again, I have a lot of tools in my toolbox, so there's a lot of things we can do non-operatively, but there's a lot of different types of procedures that can be done for this too. And this is where it's important to tailor the treatment plan to my patient's individual need. All right, now we're moving on to flat foot. This is the foot and ankle orthopedic community recently renamed it to this fancy progressive collapsing foot deformity, but really what that means is it's a flat foot. So what that means is you have more hind foot valgus, or your foot is flatter, which is the opposite deformity of the cabovarus, which we just talked about. And patients can present with pain in their lateral foot and ankle, kind of right here. Also, they can present with pain medially along their arch, as well as posterior medial, so kind of behind their ankle. And the reason why this is a problem is it can lead to pain and swelling and overall dysfunction. Patients can have difficulty with standing for a prolonged amount of time and with activity. So I always start with non-operative interventions. And the first thing that I typically like to start out with my patients is an ankle brace. The reason why I like ankle braces, is it supports that ankle and hind foot. And patients tend to get a lot of symptomatic relief from this. Other options are orthotics, both over-the-counter and custom, as well as the gold standard, which is this custom-made, it's called an Arizona brace, where it's custom-made to your foot. Of course, there's also operative interventions, which, again, it's important to tailor my treatment for my individual patient. And now finally, we have arrived at ankle arthritis. We're going to talk about ankle, midfoot, and forefoot arthritis, or big toe arthritis. So the ankle in general is less commonly affected by primary arthritis than other major joints. The reason why the ankle is less affected is differences in the articular cartilage, so the cartilage itself, joint motion, and susceptibility of that cartilage to inflammatory mediators, which is kind of the microscopic changes that happens with arthritis. When we think about the ankle joint and the knee joint, one big difference when we think about differences between the ankle and knee joint and why the knee often has more primary arthritis than the ankle. And when I say primary, that means arthritis for no reason, osteoarthritis. So no history of trauma, no rheumatoid arthritis or things like that. But one big difference between the ankle and the knee is the ankle has more conformity and containment. The talus, which is this bone right here, is firmly bound on three sides by the bone on your outside of your ankle, which is the fibula, your tibia, your medial malleolus, the bone on the inside of your ankle, as well as we call this the tibial plafond, but the distal tibia, essentially. Additionally, not only do we have this bony containment, but we have very strong ligamentous attachments, which just allow for better loading in general. Unlike if you think about the knee depends upon the meniscus for loading. Of course, with ankle arthritis, I try to treat my patients first, non-operatively, with NSAIDs, again, Voltaren gel. Joint injections, so steroid injections, can be beneficial for some patients. And then also bracing. The idea of bracing is to eliminate motion across the painful joint. And there are several different brace options, including this Arizona brace, which is custom made for your foot and ankle. Also, just over-the-counter braces can be also very beneficial. These days, there are two main procedures that we generally accept as solid, effective management for end-stage arthritis. The first one is our tried and true fusion. This is a safe and reliable procedure. Patients typically do really well with it because it relieves pain and improves function. Additionally, there's no long-term activity restrictions once the fusion has healed. Patients get worried though when they hear the word like fusion, because they worry that means they're not going to be able to walk normally and they're not going to have any motion through their foot. But often when I have a patient and I'm talking about a fusion type procedure, I demonstrate to them, because often they don't have, depending upon the amount of arthritis, but often they don't have very much motion of their ankle joint itself. A lot of their motion that they feel like they're getting is actually compensatory increase in motion in the midfoot and the hindfoot. And a similar thing happens when this joint is fused. You get more motion in your other joints typically. The other treatment we have these days is total ankle arthroplasty, or a total joint replacement of the ankle. Now, proponents for this procedure believe that it will soon be considered the primary procedure for ankle arthritis. And the idea is you can maintain your ankle motion, which may put less stress on your other joints. Some argue, however, that we don't have enough long-term follow-up data on this procedure. But we have pretty good data that's about not quite 10 years old, saying that patients do really well with this too. And now we're going to talk about midfoot arthritis. Midfoot arthritis typically presents with pain in the top of your foot. Now, like we talked about earlier, if we are given the opportunity to live long enough, our foot commonly develops arthritis. It is only a problem, though, if it's painful. This joint right here is our second ray. This is the joint that typically develops arthritis first. And it is not uncommon for patients to have pain at the top of their foot, swelling. They may also have numbness that goes into their toes. And that's because there's a nerve that runs right along the top of your foot. And when there's arthritis or loss of cartilage in that joint, our body tries to protect that painful joint by creating inflammation. That inflammation can trigger the nerve, which can then lead to numbness and tingling type sensation. The most common cause of midfoot arthritis is post-traumatic, so trauma with the foot, but also primary is not uncommon. So just arthritis for no reason. Also, patients with flat feet can get arthritis in these joints. The problem with this is it's painful. And also, you have some loss of midfoot stability with midfoot arthritis, which can lead to a flat foot and just difficulty with walking. Of course, I always try treating my patients with non-operative interventions first. And this includes stiff-soled shoes, because it's important to protect that painful foot. There's two ways in which we can go about making your shoes hard, if you will. Number one, buying new shoes. One of my favorite type is the Hoka. However, for people that have balance issues, Hoka isn't great because of how high that heel is. But the reason why I like Hoka is it's rigid. So if you were to try to bend it, you can't. So it protects that foot. Also, with this thick heel or this thick sole, it's very cushiony. And also because of this toe off, see this rocker bottom, it's easier to walk because instead of depending upon the motion through your midfoot, this type of shoe kind of helps propel you forward. Another thing that I use in my clinic is a carbon foot plate. The carbon foot plate is the thickness of a credit card, so it's very thin. Can pretty much go into any shoe. Most shoes these days have an insole that come with it, so you lift it up, slide it right under there, and it essentially makes any shoe a stiff-soled shoe. Other things that can be used would be Voltaren gel or a steroid injection. From a surgical perspective, there is a couple different options. The midfoot fusion is really the gold standard. However, other things have been described that are actually not bad ideas for older patients with bad midfoot pain, including oftentimes with midfoot arthritis, we also have a tight calf muscle. So some people have tried cheating midfoot arthritis by lengthening the calf muscle, therefore taking off pressure of that painful midfoot. And some authors suggest promising results with that. And finally, we have made it to big toe arthritis. So hallux rigidus is the scientific name for this, and this is really arthritis of this joint right here. Or as we can see in this pictures, this one. And arthritis, so there's 4 hallmarks of arthritis: joint space narrowing, bone spur formation or osteophyte formation, sclerosis, see how white this bone is, and then also erosions of that joint space, of the subchondral bone, we call it. And you can see that here, how this is white, so that's sclerosis, pardon me. This is darker, so this is like erosions of the subchondral plate. But the reason why it's important for patients is because it can be painful. Again, can cause problems with walking. So I first start treating patients in a similar manner with stiff-soled shoes, like the Hoka or the carbon foot plate, Voltaren gel. Also, steroid injections are an option. There are several procedures that are described for great toe arthritis. Not all of them work very well. There are 2 procedures that I think do very well for patients. Number 1 is, I like to say, kind of a cheating procedure called the dorsal cheilectomy. And that is where you literally just shave off this bone spur. And because that bone spur is then shaved off, you can move your joint without impingement or without those bony pieces running against each other, which can help relieve pain. The other option is a first MTP fusion, like seen in this x-ray. And again, fusion can sound scary for patients. And one of the most common questions I get is what will happen to my gait, or will I still be able to walk normally? And research and evidence shows us there's actually improvement in gait and walking in both power and stability. And that's all. We will now look for your questions. Okay.
All right. Right now, it does not look like we yet have any questions. So we're still looking. Okay. You still have time. If you have questions, please type those in. We'll just do kind of our closing, and if anything pops up, we'll have you jump in. So thank you, Dr. Christofferson.
Thank you.
Great presentation, lots of good information, and my ears perked up several times. People I know or myself, so thank you for all of that information. I want to remind everyone of our upcoming Primetime Alive programs. Our next one is Thursday, January 6th. Dr. Peter Buck is doing a program called Ice Storms, How to Keep Yourself Out of the Emergency Room. This kind of comes out of his years as an orthopedic surgeon and all the people he saw following an ice storm, and he would rather prevent that than have you have to come in to the emergency room. And then Thursday, January 20th, we have a program Motivated to Move, and that is Brenda Baker, who is our supervisor at our Lifetime Fitness Center. And then Wednesday, January 26th, also at 2 p.m., we have a program, Faith and Spirit as We Age, and that is Catherine Werner, our chaplain, one of our chaplains here at the Medical Center. So once again, thank you. Oh, okay. So I'm going to thank everyone and thank Dr. Christofferson. We do have a question here. What is a bunion?
That is an excellent question. Now, can we go back to my, oh, no, can they still see that or no?
I think they can. Tim, yeah, that's what they should see.
Yes, they can still see it.
Yep, there you go.
Can I move slides? Can I go back to the previous slide?
Here you go, yep.
I can just do that. Okay.
There you go.
All right. So the question is, what is a bunion? And that's a great question. That a bunion is, let's see here. So a bunion can represent a couple of different things. From a medical perspective, what a bunion says to me as a foot and ankle orthopedic surgeon is you have this funny shaped great toe. So instead of at your first joint, you have this big bump that sticks out medially. Now, that is a bunion, but also if you look at this picture, this kind of looks like it could be a bunion because sometimes our osteophytes or the bone spurs can resemble a bunion, but in fact is different from the reason why it's there. And for you guys, that's not as important as it is for me to understand as a surgeon, because if I don't treat you appropriately, your pain is not going to improve. But if we talk about a bunion in and of itself, where there's no arthritis in that great toe, that's just where you have this big bump medially at your great toe. And that is only a problem if it's painful for people. My mentor in fellowship is incredibly well known for bunions and great toe arthritis, actually. And she famously would always show people her feet because she had horrible bunions herself. And she would show them to her patients because she wanted them to understand surgery is not without risks. And if you have daily walking pain because of your bunion, that is the reason to get it fixed. The reason it is not a good reason to get it fixed because you don't like how it looks. But a bunion can be painful. And it really, to simplify it, is a bump on that medial side of your great toe. Now, if you have a bump on the top of your great toe, like this picture here, that more commonly represents arthritis. I hope that answered your question.
Do you do bunion surgery?
I do. I do bunion surgery.
Okay.
Yes.
All right. Tim's getting it back there for us, and it looks like that's our only question.
Thank you, everyone. Again, I hope to someday see your beautiful smiling faces rather than an empty computer screen. But it has been my honor. Thank you for your time.
And I, too, hope to see those beautiful faces because we've years and years did these in person, and one day we will get back to those. So again, thank you, Dr. Christofferson. Stay safe, everyone out there, and happy holidays. Thank you.